care for patients at risk for ARDS, and I tried to make some suggestions on how to make future definitions a little bit better. And then I'll give you some practical approach how to treat patients with ARDS, because basically ARDS is an iatrogenic syndrome, because the lungs normally are a pretty dry place. And most of all, after fluid overload, patients can get wet lungs. I forgot to disclose that I also received this beautiful dress in blue velvet and golden broderie from an Uzbekistan professor. I just wanted to share this. And I also have to disclose that I have some bias when it comes to abdominal pressure monitoring. And this was a painting given by the students a couple of years ago after their training in our hospital. And some may think that this abdominal compartment society is kind of a cult or a sect, and I have to admit that sometimes we do speak Latin. But what I really need to know, and we alluded to in the morning session, is an answer to 4 basic questions. The best fluid is probably the one that has not been given to the patient unnecessary. Okay, so keep on talking without the slides then. The second question is, when shall I stop giving fluids? The third question being, when patients are fluid overloaded and are not mobilizing the excess fluids themselves, they may need a little help with diuretics or maybe ultrafiltration. And when we are unloading our patient, at some point in time, we may need to stop, because hypovolemia may be detrimental as well. And now I just would like to ask if there is a possibility. Okay, let's ask a question. Who likes the ARDS definitions, the Berlin definitions? Can you? I haven't told them, but maybe you can already say if you like or dislike. Who likes? Who dislikes? And the others are waiting for the slides. Okay, yes. Mervyn, do something.
I think it's like everything, you know, it's just there just so that people talk the same language. You're not going to treat a patient any differently because they've just gone from, you know, mild to severe, you know, so therefore it's just a way of saying, okay, when we enter somebody into a trial, accepting you can manipulate the people, whatever, to change the PF ratio, but it's just something to try and deliver consistency for coding epidemiology, etc.
It's more for research than that you can subdivide into groups and then compare outcome.
But it doesn't, in clinical terms, it doesn't make any difference. You're still going to treat the patient, and you're not going to suddenly cry or laugh just because their PF ratio is a little bit worse or a little bit better. It's, you know, so that's why, you know, it's just trying to describe a syndrome with lots and lots of different phenotypes within that.
Fully agree. So first of all, the definition states it's a syndrome. So it's not a disease. There can be many diseases causing this syndrome. So in such a way, there is no cure for ARDS, but there may be a cure for the underlying disease, which may be sepsis, infection, capillary leak, and poor fluid management, fluid overload, which brings me to the sponge model, because the lungs are dry, but if we fluid overload them in the setting of a capillary leak, especially if abdominal pressure is increased, then you get this full-blown picture. And I see my slides are back over there, but not over here. No problem. So, whenever you have a therapeutic dilemma, you need to make choices. And the therapeutic dilemma means any situation where one treatment may cause harm to one organ function. So it could be the kidney in the beginning if the patient is underfilled, but it could be the lungs at the end if the patient is fluid overloaded. But the thing is that we always need to support the organ that carries the highest danger or the highest risk for killing your patient. So it may be the lungs on one day, the kidneys on the other day, the heart or the liver later on. So the modern era of acute lung injury, we may not use this term anymore, we now only use ARDS, dates from the wars in the 50s and the 60s, where soldiers were wounded and had hemorrhagic shock and given fluids. As said, it's a syndrome, not a disease. And the initial, The initial publication was the paper by Ashbaugh in The Lancet in 1967, and the definition was that it was vascular congestion, atelectasis, pulmonary edema, refractory cyanosis, and hyaline membranes. So what are the American-European consensus definitions of ARDS? They were published in 1994. And basically, it comes to these 4 points. It's an acute disease, so it could be either a trauma, which we know is associated with ARDS, or a sepsis, bilateral infiltrates, a PF ratio below 300, no evidence for right or left heart failure. So it was thought that maybe it's time for a change of these definitions from 1994. And around the same time, there were 2 publications. One was a clinical review, a consensus of 16. And then came in the JAMA 2012 the new Berlin definition for ARDS. What are these new definitions? So they defined acute. What is acute? It needs to be within 1 week. Chest X-ray must show bilateral opacities, not fully explained by pleural effusion or atelectasis. And there must be edema, respiratory failure not explained by cardiac failure. And now we added this subclassification into mild, moderate, and severe based on the PF ratios. So during this discussion preceding the new Berlin definitions, a lot of criterions were evaluated. But as you can see that at the end, there were some reasons why they have not been included, like high PEEP or low compliance, or dead space ventilation, plateau pressures. Extravascular lung water, what we are talking about today, was not included because the committee esteemed it not to be feasible at that time, maybe other biological markers. And my personal bias is that I feel that abdominal pressure should be included because a patient with primary or secondary ARDS, secondary meaning abdominal sepsis, are different patients and need to be ventilated differently. So these are the new Berlin ARDS definitions. So my question is it any better than the old ones? Do they differ? So I've put them next to a side. So in the old days, we had acute lung injury, and then we had ARDS with the cutoffs. Now we have mild, moderate, severe. But I can't see much of a difference in these 2 definitions. What's in the name? I don't have this wow effect. I was not waiting more than 15 years for these new definitions. So point by point, these were the issues addressed in the new definitions when it comes to timing, category, the oxygenation levels, chest radiography has been explained, the wedge pressure has been abandoned, and the risk factors have also been identified better. So there is some improvement as we describe. This is getting really difficult as we describe better each item which is included in the definition, so to get more homogeneous patient groups. So ARDS, it was 67 Ashbaugh paper, so now we are 2017, so it's 50 years anniversary. And there has been a number of papers published in intensive care discussing these 50 years of ARDS and how things have evolved and whether the new definitions meet our needs. Yes, no, not sure, maybe. So why? Why is the Berlin definition wrong, or could it be better? Well, if I just ask it on the internet, 54% does not like or is not sure. Well, for sure, the internet isn't always right, but it gives some flavor that people at the bedside, they are still struggling with these definitions. So what is wrong? There is a minimal PEEP set in the definition, which means that the disease or the syndrome cannot exist unless it's being treated with the ventilator and the PEEP, which is a bit weird. The radiologic criteria, they are not sufficiently sensitive or specific, and PF ratio still has poor predictive value. So the Berlin definition has poor predictive value for outcome, does not correlate well with the pathophysiology, as I told you, extravascular lung water or diffuse alveolar damage, which is seen at autopsy. Parameters are insensitive. Acute, they define it as 7 days. Why is it 7 days? And it requires something that happens in 89% of the time with our patients. We do give a low level of PEEP of 5 centimeters of water. So in this study, you can see that 50% of these patients with acute respiratory distress syndrome had PEEP levels above 10. And if you control for PF ratio, the PEEP did not predict mortality. So why is it included then in the definition? It may affect the definition because the PEEP will change the PF ratio. So your condition changes from mild, moderate to severe based on the PEEP. As you can see in this study, if you put the PEEP, then the PF ratio increases and your ARDS severity decreases, which is not logic to me. It's a one or none phenomenon. You have ARDS or you don't. The FiO2 also has an impact on the PF ratio. Is this ARDS on the chest X-ray? Can you tell? Well, the one on the left had ARDS with an extravascular lung water of 15. The patient on the right did not have ARDS because this was pleural effusions. So chest X-ray does not correlate with pulmonary edema. This is a patient with definitely ARDS in whom was recruited, PEEP applied, hypertonic albumin and furosemide, and you can see that after 1 day, the lungs were cleared of the alveolar edema. The lungs not being sick, just having the capillary leak. So the treatment, putting the PEEP or changing the fluid balance, affects also the definition. So the European definition of shock is an imbalance between oxygen delivery and consumption, and within oxygen delivery, you see cardiac output. So by definition, if you want to treat a patient with shock or ARDS, you need cardiac output. Cardiac output is my friend, and we know that some friends come with benefits. Some modern monitors have a lot of more parameters than just the cardiac output. So use these benefits. So don't look only at the cardiac index, but at the volumetric preload indices and at extravascular lung water, as it can make a change at the bedside. Could I ask who is measuring extravascular lung water? Could you just raise your hand? Okay, that's fair enough. I would say with the chairman, it's about 25.9% of the audience, which is okay, but I think could be better. If this is a pint of beer, it's about half a liter in England. In Belgium, we have 25 centiliters. We have 33. Half a liter is already a lot in Belgium. So half a liter is exactly the amount of fluids in the extravascular space in normal situations with you here at this moment in time. If I would add another 200 or 300, then you would be in overt pulmonary edema. So say it again, the fluids from the lungs need to be drained via the hilus, transpleurally, transabdominally, and there's only 3 ways. Which brings me to the Burj Al Jarab, where Agassi and Federer had this tennis match, and on top of the Burj there was a tennis court. And the surface of a tennis court is around 88 square meters, which is about the surface of your alveoli if I would cut them and put them next to each other. So pouring out a glass of beer or any other fluid, 500 ml, on top of a tennis court will render you in overt pulmonary edema. So the lung is a pretty dry place, and it needs to be dry for gas exchange and surfactant function and recruitment. So I believe that by definition, the new ARDS definition should have extravascular lung water in it, because the cardinal sign is capillary leak. And with the current definitions, not including extravascular lung water, about 50%, 1 in 2 of the so-called ARDS patients do not have ARDS in fact. The other important thing, I believe, is intra-abdominal pressure, because intra-abdominal hypertension dramatically has an impact on villi, on lung recruitment, distension, and also extravascular lung water, as well as lymphatic drainage. So if you look at CT scan of patients with ARDS, you can identify these ventilated, recruitable, and collapsed areas. So it's the sponge model. And by definition, to me, it's an iatrogenic disease because of fluid overload in combination with the capillary leak, but you can only leak what you have in your veins. So what have we forgotten? I think the pathophysiology of fluid overload and fluid overload causing end organ failure and damage. Capillary leak can occur in minutes after the insult, and this is what you fantastically see with burn patients. Moreover, capillary leak can occur at a distance. This is a hamster cheek path where you look at the microvessels and you label it with radioisotope dextrane, and now you induce a chemical peritonitis, but you're still looking at the hamster cheek. So after 10 minutes there is a leak, after half an hour there is a leak. So capillary leak can occur at a distance, and that's why saline and crystallets in general may suck in patients with sepsis and capillary leak and can lead to fatalities, as was the case with this teenager in Australia. So we need to do better, because fluid overload really is not cosmetic. It has a dramatic impact on end organ function. So one more thing. How can we monitor this capillary leak? Well, there are many parameters, like colloidal oncotic pressure. Also, the capillary leak index might be interesting. Whenever there is a first hit, whether it's trauma, sepsis, or burns, we need to give fluids. They are life-saving, and it's early goal-directed, and fluid balance must be positive. But at some point, we must come to conservative fluid management and late goal-directed fluid removal. A capillary leak index, I'm just stating it here, but look at it when you're back home. It's the CRP divided by the albumin, and it increases on day 3. And if it stays increased, those are the patients that may end up dying. Extravascular lung water is associated with poor outcome. So the higher, the more chance you're dying. And in this study, we found that non-survivors have a higher extravascular lung water. But the delta was also positive. So meaning if it's high and it keeps on increasing, then you're most likely to die. So a drop in the extravascular lung water is a good predictor for good prognosis. And if you identify a non-responder as the patients who keep on having a high extravascular lung water, you can see that those are the ones with a positive cumulative fluid balance, and those are the ones, if they are responder, meaning if extravascular lung water drops, you're more likely to survive and you're more faster off the ventilator. Also, if you're able to do conservative late fluid management, which is 2 negative fluid balances consecutively in the first week of stay. It is an interesting study, albeit already quite old, from '92, comparing SWAN treatment versus extravascular lung water, and you can see that mortality rate is lower if you treat the extravascular lung water, if you get rid of the excess fluids. Another interesting parameter is the ratio between the extravascular water and the pulmonary blood volume, which is the pulmonary vascular permeability index. And stay with me that in case of sepsis, you're hypovolemic with a lot of lung edema, so this index will be much higher in sepsis. And this was found in the study in dogs, that in inflammatory pulmonary edema, the PVPI is higher, and this has been validated in the clinical setting by the group of Xavier Monet. who found a cutoff. If the PVPI is above 3, then the pulmonary edema is probably hyperpermeability. And it has a better discrimination than the brain natriuretic peptide. So if you fill up a patient and you increase the preload, you increase cardiac index up to a certain point. But at the same time, you may have raised or chased the patient into pulmonary edema, because a small increase in the preload at the end may result in a very large increase in extravascular lung water. So if I may, one last more thing. If we go back to the papers about 50 years of ARDS, what are the therapies? And I'm not going into detail. You can read it. It's open access. And there are nice algorithms, what to do, supportive measures, proning the patient, nitric oxide, maybe ECMO, there may be a place. PAL treatment may be your friend in ARDS. So it's a combination of a PEEP set to the level of the abdominal pressure to counteract lung collapse. You squeeze out the fluids out of the alveoli into the interstitium. You push the fluids into the vascular space, and by adding the hyperoncotic albumin, you get the fluids out of the lungs into the blood, and with the diuretics, you get it out of the patients. So this is the acronym PAL treatment. So we've done this in an observational study with matched controls, 114 patients. So the PAL group, higher PEEP, the albumin was substituted up to 30 grams per liter. And you see after 1 week, we saw a drop in abdominal pressure, better oxygenation, drop in extravascular lung water, but mainly because we kept the fluid balance in balance. And this resulted in a better survival and a faster weaning of the ventilator just by treating the extravascular lung water. If I may, just one very, very last thing. So how can we improve it? Because that's the question. I think we need to use modern imaging techniques like CT scan, counter-Hansfeld units, PET imaging may be helpful. Lung ultrasound, we've been heard this during the meeting, can be helpful to identify B lines. Electrical impedance tomography may also be interesting to discriminate ventilation and perfusion mismatches. So I think we need to use modern tools in the ARDS definitions, and maybe with extravascular lung water in combination with PVPI. So we proposed a couple of years ago a new and simple definition where we would like to coin the place for extravascular lung water. And maybe we need to rename ARDS like diffuse alveolar damage, because this is what you see at autopsy. So, ladies and gentlemen, Chairman, to wrap it up, I think we need to differentiate edema of lung injury. It could be pneumonia, fusion atelectasis, aspiration, so there is a lot of things that can be confounders. The PF ratio and the PEEP may affect the definition. So we need better classification. Definitions must reflect always pathophysiology, and definitions must guide our treatment, which the current definitions don't, but including extravascular lung water may, because I believe that this, by definition, ARDS definition should have extravascular lung water. It reflects pathophysiology and outcome, and it is a guide to de-resuscitation. Thank you for your attention.